The title of my talk is Strengthening Snakebite Care and Reducing Snakebite Deaths. Following a background of the problem of snake envenomation in India, I will be discussing 4 cases on neurotoxic snake bites, hemotoxic, acute kidney injury, and thrombotic microangiopathy, and the problem of antivenom ineffectiveness, and lastly on steps to strengthen snakebite care and reduce snakebite deaths. We'll start off with a video.
A few years ago, during one of our frequent visits to Ghana, a local doctor drew my wife Nan's and my attention to the devastating impact that snake bites were having on the community. I was shocked to hear that snake bite kills between 81,000 and 138,000 people globally every year, with many more suffering lasting mental and physical impairments. By comparison, the mosquito-borne dengue fever claims roughly 20,000 lives annually worldwide. Snakebite is essentially a disease of the poor, mostly affecting populations living in some of the poorest, most rural communities of sub-Saharan Africa, Asia, Oceania, and Latin America. Small farmers, their families, herdsmen, and displaced people are particularly vulnerable. Despite its huge impact, snakebite is the biggest public health crisis you have likely never heard of. It never makes the headlines. To date, it has been largely overlooked. But it is also a challenge that can be solved. It should not remain a forgotten crisis, and we need to take immediate, robust, and sustained action. Affected countries, partners, and stakeholders have to mobilize adequate funding for public health systems and implement relevant policies and programs aimed at improving the prevention and effective treatment of snakebite. Owing to its leadership in global health issues, the World Health Organization must be adequately resourced to be able to tackle this crucial issue. Close collaboration with industry partners can ensure that safe and effective antivenom becomes available in all countries affected by snakebite and is affordable, including for the poorest and most vulnerable. By working together to tackle snakebite, we can save the lives of tens of thousands of our fellow human beings in some of the poorest and most marginalized regions of the world.
Stop. The Million Death Study, published in 2011, estimated that there was an annual snakebite deaths in India of 49,500. And the main risk factors for death were a rural location, farmers, the monsoon season, and 75% of the deaths occurred out of the hospital. At CMC, we see about 150 envenomations every year. 75% are hemotoxic envenomations, predominantly the Russell's Viper envenomation syndrome. They are mostly referred cases requiring dialysis, blood transfusions, and ICU care, and our overall mortality is 3%, and all the deaths that we saw over 1 year were all Russell's Viper envenomation. Mrs. N is a 36-year-old lady complained of snake bite. She woke up at 3 a.m. to go to the bathroom when a 1-foot black snake was found and she went back to sleep. At 5 a.m. she developed upper abdominal pain and drooping of the eyelids. She went to the government hospital and was given 10 vials anti-snake venom, after which she developed breathlessness. She had features of anaphylaxis. At this point, she was referred to CMC for further management. On examination, there was no fang mark or local swelling. Her respiratory rate was 40, her oxygen saturation 85%, and her GCS was 9/15. She had neck muscle weakness and drooping of the eyelids. What is the biting species likely to be? How should the anaphylaxis have been managed? What could have been done to prevent anaphylaxis? What precautions should have been taken while transferring her? And how will you manage the neuroparalysis? This was the snake that was brought with the patient, the dead snake. This patient had clinical features of common crate bite. He was bitten while sleeping on the floor. There was no local envenomation. There was abdominal pain and paralysis. And the common crate was identified by the white bands that you can see, a white belly, and enlarged hexagonal scales along the spine. For the management of anaphylaxis, the antivenom should be temporarily suspended. Injection adrenaline 1 in 1000, 0.3 to 0.5 ml every 5 minutes till the anaphylaxis reverses. Salbutamol nebulization for the bronchospasm, antihistamines and hydrocortisone, a supine position, elevation of the foot end, a large bore IV line, mask oxygen, and to restart the antivenom infusion after the anaphylaxis resolves. For the prevention of the antivenom reaction, prophylactic injection adrenaline 1 in 1000, 0.25 ml subcute before antivenom infusion prevents severe antivenom reaction. In an important RCT conducted in Sri Lanka, it was shown that subcutaneous adrenaline given before antivenom reduced severe antivenom reactions by 43% at 1 hour and 38% up to 48 hours, and that hydrocortisone and promethazine were ineffective, and that hydrocortisone negated the benefit of adrenaline. For this patient's transport, the NIM should be immobilized. This patient should be stabilized after the antivenom reaction before transfer, should be transferred with a trained medical attendant with oxygen by mask to maintain airway and monitor vitals, and to be prepared for intubation in case of hypoventilation or failure to protect the airway. For the management of the neuroparalysis in the casualty, oxygen should be started by reservoir bag. We should be prepared for intubation and ventilation, the indications being acute respiratory failure, low GCS and neck muscle weakness, all of which this patient had, and to administer a second dose of antivenom, 10 vials over 30 minutes with prophylactic adrenaline. Since this is a crate bite, we would not administer neostigmine. However, if this was a cobra bite, we should consider the use of injection atropine followed by injection neostigmine. If we look at the mechanisms of neurotoxicity with the neurotoxic snake bites, the cobra toxin competitively binds to the acetylcholine receptor, causing paralysis. On the other hand, the crate toxin and the Russell's viper toxin act at the presynaptic junction, and in both these cases, neostigmine may not be beneficial. The second case is a 30-year-old man who presented with history of snakebite 4 hours ago. A tourniquet was applied and he was transported to the nearest hospital. A whole blood clotting test was found to be positive and he was administered 10 units of antivenom. After 6 hours, he was found to still have a prolonged whole blood clotting test and he was referred to CMC. In CMC, he was found to have melena. His WBCT was not clotting at 20 minutes. The PT was prolonged, the INR prolonged, the APTT prolonged, the platelet count was 70,000, and the fibrinogen level was low. Which species is likely to have bitten this patient? How will you diagnose venom-induced consumptive coagulopathy? What is the mechanism of VICC? When should you remove the tourniquet? And how will you manage the VICC? The hemotoxic snakes that we see in Vellore are the saw-scale viper and the Russell's viper. The saw-scale viper syndrome is that of hemotoxicity with local swelling and necrosis. The Russell's viper syndrome includes this with or without acute kidney injury, neurotoxicity, and the permeability syndrome. This patient could have been bitten either by a saw-scale viper or a Russell's viper. How will you diagnose venom-induced consumptive coagulopathy? The test of choice is the 20 WBC, the whole blood clotting test, in which we collect 2 ml of venous blood, directly transfer it to a clean, dry glass tube. This should be maintained upright, open, and undisturbed for 20 minutes. After exactly 20 minutes, the tube must be inverted. If a solid clot is retained, that indicates a normal coagulation, that is a negative test. If the clot breaks down quickly upon inversion, or if there is no clot, this is a positive WBCT, which is diagnostic of venom-induced consumptive coagulopathy. There are some problems with the 20 WBCT. If you don't use a glass tube, or if you use a glass tube washed with detergent, you can get a false positive WBCT. At Vellore, we have also developed a modification of the WBCT called the Vellore manually activated clotting time. Instead of using glass to activate clotting, we use kaolin with a glass test tube, and this result is available within 4 minutes. The sensitivity and the specificity of the VEMAC test is higher than that of the WBCT, and it's a very low cost to perform this test. The mechanisms of VICC differ between the saw-scale viper and the Russell's viper. The Kaolin toxin of the saw-scale viper activates prothrombin and causes the consumption of fibrinogen, leading to the coagulopathy. On the other hand, the Russell's viper venom acts at multiple sites. It activates factor 10, factor 5. It causes consumption of fibrinogen, fibrinolytic effects, as well as direct tissue hemorrhage. So at Vellore, we see 2 patterns of VICC with a saw-scale envenomation, pure VICC with a positive WBCT, a prolonged PTINR, which responds to the first dose of antivenom with low rates of transfusion. On the other hand, with the Russell's viper envenomation syndrome, we have a positive WBCT, a prolonged PTINR, thrombocytopenia, and microangiopathy as evidenced by thrombocytopenia, hemolytic anemia, and the presence of schistocytes. This is associated with increased rates of bleeding and higher requirements of blood transfusion, and an increased requirement of a second dose of antivenom. The tourniquet should be removed after the first dose of antivenom in order to prevent rebound envenomation that can occur. For the management of the VICC, this patient requires another repeat dose of 10 vials of antivenom over 30 minutes preceded by prophylactic adrenaline, to consider cross-match and transfusion of FFP if systemic bleeding persists, and to repeat the WBCT after 6 hours, and if that is normal, no further treatment is required. And the indications for transfusion are systemic bleeding despite antivenom therapy, and where ASV cannot be administered due to severe antivenom reaction. The third case is a 54-year-old vendor who was bitten at 10:45 and a tourniquet applied to the left ankle. He presented to a government hospital 3 hours after that. At admission, the 20 WBCT was negative. 6 hours later, the WBCT was positive. 8 vials of ASV administered. 12 hours later, the WBCT was still positive. 10 more vials were administered. At 18 hours, the WBCT was negative. At this point, the patient started developing abdominal pain and decreased urine output and was referred to CMC. At CMC, patient presented on the third day after bite with complaints of reduced urine output. There was mild swelling of the dorsum of the leg. There was some bleeding from the bite site. And on catheterization, the patient was found to be oliguric with a dark brown urine. The admission investigation showed a hemoglobin of 11.4, 2% schistocytes, thrombocytopenia, elevated LDH, elevated serum creatinine, and a normal PT-INR. Which species is likely to have bitten this patient? What is the clinical condition that this patient has developed? What is the pathogenesis of this condition, and how will you manage it? This was a snake that was brought with this patient. This is clearly a Russell's viper envenomation. The diagnosis in this case is a Russell-induced thrombotic microangiopathy, as evidenced by the AKI, the falling indirect hyperbilirubinemia, elevated LDH, the thrombocytopenia, schistocytes, and a normal coagulation profile. This patient was treated with plasmapheresis with 8 units of cryosupernatant on day 3 with an improvement of the platelets, improvement in the hemoglobin, and a decrease in the lactic dehydrogenase. What is the pathogenesis of the thrombotic microangiopathy? As we know, in the capillary and in the vessel wall, there are ultra-large von Willebrand factor multimers. An enzyme ADAMTS13, a metalloproteinase, is actually involved in cleaving these multimers and preventing formation of platelet microthrombi. If there's a deficiency of ADAMTS13 or an ineffective ADAMTS13, we can get the formation of multimers and platelet microthrombi, which can block vessels and cause organ dysfunction. So thrombotic microangiopathy is associated with a severe deficiency or ineffectiveness of ADAMTS13. And the treatment of choice is replacement of ADAMTS13 and removal of ultra-large multimers with plasma infusion or a plasma exchange. This was the first report of the association of thrombotic microangiopathy with Russell's viper, which was published by Professor Anand Zachariah and Professor JCM Shastri in the year 1986. In this publication, they had 24 cases, and all the snakes that were identified were Russell's viper. Most of the patients with a classical triad of involvement, and in 5 patients on the kidney biopsy, they were able to demonstrate platelet microthrombi in the vessels, thereby confirming the diagnosis. Our recent experience of thrombotic microangiopathy has shown in Vellore that 10% of hemotoxic snakes have thrombotic microangiopathy, and all were due to a Russell's viper envenomation syndrome. In our retrospective series, our mortality was 27%, and this was reduced to 0% in prospective study, probably due to improved management. So how do we manage the Russell's viper-induced thrombotic microangiopathy with cryosupernatant or FFP at a dose of 10 to 15 ml per kg? Plasmapheresis in cases of severe TME, dialysis when indicated, and to avoid platelet transfusion as it may worsen the thrombotic microangiopathy, and good supportive management. The last case is from a collaborative study that we did between CMC and the government Vellore Medical College. In 2014, there was a sudden increase in death rate due to snake bite in the snake bite season in the government Vellore Medical College. Various infrastructure, equipment and training issues were addressed, despite which the mortality continued. Withdrawal of 2 batches of antivenom led to a fall in the mortality. The biochemical analysis of these batches showed that they had lower antibody titer and also reduced binding to specific venom proteins. The Indian polyvalent antivenom, if you look at the information sheet, This is the information that each ml of antivenom neutralizes a certain amount of venom of the big four, and this is based on preclinical information. The dose of antivenom today is determined by preclinical information, but not based on proper clinical dose finding and efficacy studies. And this is a regimen that we use based on the preclinical information, an initial dose of 10 vials in the case of neurotoxicity. If there's neurological worsening or persistence of weakness, a repeat 10 vials. In the case of hemotoxicity, a positive WBCT after 6 hours necessitates a repeat dose of antivenom. So the problems with the Indian polyvalent antivenom are the lack of dose finding and efficacy studies, antivenom reactions due to impurities, and in CMC, we have about 34% of our patients have antivenom reactions, and 1/3 had severe antivenom reaction. And as this case study highlights, the problem of batch-to-batch variability, and also we see syndrome-related ineffectiveness. There's some data about the relative ineffectiveness of Indian polyvalent antivenom for Russell's viper envenomation. So when we define effectiveness of the first dose as a normalization of WBCT at 6 hours, in pure hemotoxic envenomation, we found 70% of patients had normalization. However, with the Russell's viper envenomation syndrome, only 44% had normalization with the first dose, and the majority of patients required a second dose of antivenom. What are the reasons for the variability of antivenom effectiveness? A single source of venom from the Irula cooperative in Mamallapuram, and this also problems of the lack of quality control. We know in our country that for all the big four species, there is variation in the composition of the venom across the country, and therefore you need multiple sources of venom for antivenom manufacture. Problems related to horse immunization, purification steps, and quality control. The WHO has advocated various steps towards improving snake antivenom: improvement of quality with a geographically representative venom pool, strengthening of antivenom manufacture by reducing impurities, increasing potency, and meeting the WHO good manufacturing practices, independent preclinical testing, and clinical antivenom studies of dose finding and clinical trials. And finally, what are steps that we can do to reduce snakebite deaths? The WHO put forward in the last year a strategy to reduce the burden of snakebite deaths by 50% by the year 2030. And this involves assessing burden, a snakebite registry, the training of health personnel, strengthening of health systems, and strengthening availability and quality of antivenom, public awareness of snakebite, and research and development. So we look at all the different causes of snakebite in India. One is snake-human interaction. Patients have delay in care due to use of traditional practices, delays at the level of ambulance, weaknesses and lack of staffing at the primary health center, and problems at secondary and tertiary care. The various interventions that can be used to reduce snakebite deaths are public education, first aid and pre-hospital care, adequate stocking of antivenom, emergency care, diagnostics and training, and good support at the level of secondary and tertiary care. So these are some steps that are happening in our district. In our own hospital, we educate all our patients at discharge on how to prevent snake bite. And we know the important messages are to use a torchlight at night, make sounds on the ground with a stick or the feet while walking in the dark, not to sleep on this floor, to use mosquito nets which can prevent snake bite, lighting around the house and space between the house and the surrounding vegetation. And we also conduct school education on the main prevention messages. An important initiative in Tamil Nadu is the Tamil Nadu Accident Emergency Initiative, one of the 6 pillars of which is poisoning and envenomation. So there is a surveillance system and snakebite registry that has been recently implemented in Tamil Nadu with guidelines, training and monitoring. And there are nodal training centers, of which Vellore GVMC is one of them, with 77 Thai centers on a hub and spoke model. This is data from the Thai registry on October the 8th of this year, and on that one day there were 99 bites and 3 deaths. And this is real-time data that is available from the registry on what is happening to snake bite. In Department of Medicine, we have also initiated a poison information center which provides 24/7 information we need on poisonings and envenomation. These are the numbers. So finally, what can each of us do towards preventing snakebite deaths? This is information, a story from the New York Times. Sajah Begum was cooking dinner when her son walked into the kitchen with a stricken look on his face. "Mother, I've been bitten by a snake." Ms. Begum could not call the ambulance. She trekked across the landscape of cut-off streets, security checkposts, disconnected phones, and hobbled doctors. On August 13th, her son, Amir Farooq Dar, a student whose college had been closed since early August, was tending his family's sheep when he was bitten by a crate. The village public health center was closed. She begged for a ride to the Baramulla district hospital, but they could not locate any antidote. They somehow arranged an ambulance to a hospital in Srinagar. Soldiers stopped the ambulance many times on the way. They finally made it to the Saura hospital in Srinagar, and the hospital did not have any antivenom. In Srinagar, they traveled frantically from pharmacy to pharmacy, pleading for antidote. They arrived at the gate of an army camp, which normally stocks antivenom, but they were told to come the next day. Mr. Dad said he had never felt so helpless in his life. "I felt like pushing a knife into my chest." At 10:30 a.m. the next day, 16 hours after he was bitten, Mr. Dar died. His parents then traveled 55 miles back home in an ambulance with a dead body. The question I would like to pose to each of you is, what should you do and what would you do in a similar situation? Thank you.
Thank you very much, Anand. In the interest of time, we'll have one question. Sir. Anand, there was some information about continuous infusion of antivenom, so published from Kerala a long time ago. Has that been compared with this bolus injections?
No, sir. No good comparative trials. Actually, the amount of information that we have are individual centers and small studies. So I'm not aware of any information on the question that you're asking.
It was a Lancet article published a long time ago from Kerala, showing continuous infusion of antivenom. They were able to make do with smaller quantities.
No, actually, we did in medicine too a study between bolus and continuous low-dose infusion. And low-dose infusion, I don't remember the exact year, low-dose infusion, the total requirement had come down from around 25 to 16 or 15. And it had better outcomes related to outcome of poisoning. This was exact time, I think it was one of the theses, if I'm not mistaken. I don't know whether
David Trehan's publication.
I asked the question because of the half-life of the antivenom. The half-life is supposed to be rather short, and so a continuous infusion might work better than bolus doses.
Yeah, so I'm from Pushpagiri Medical College. So we had came across some viper venom which has got a prolonged clotting time. Even we have done platelet count and APTT, PT, everything was normal. Actually, the patient doesn't have any bleeding manifestation. The only problem is the patient has got a prolonged WBCT. We have observed the patient for 10 days and slowly the WBCT has come down. What is the cause for that? Or anything to be done for that?
So the hump nose viper bite is what is well known in Kerala. There are several species outside the big four, which are known in India. And in the south, the most relevant is actually the hump nose viper. The The viper venom is not utilized by the polyvalent antivenom, and the treatment of choice, if it is recognized hump nose viper, is not to give antivenom and supportive management with blood transfusion where required and dialysis if they develop acute kidney injury. This has been well published in the literature.
Hump nose viper is very common in Trivandrum. I am coming from Trivandrum Medical College. We used to see 1 or 2 or 3 cases per year, and they present with the prolonged clotting time. And as you said, the ASV is not effective, but we usually watch the patient. Only when they develop overt bleeding, we used to give fresh plasma plasma. Otherwise, it's not necessary, sir.
Thank you.